Welcome to OncoPharma. I'm your host, John Bazar. I am a professor of pharmacy practice here at the supporting sponsor of OncoPharma, ETSU's Bill Gatton College of Pharmacy. It is the last Thursday before Christmas 2025, late in the day on Thursday, getting this out. I'm going to talk a little bit about what might be kind of some paradigm shifts in bladder and urothelial cancer, and then a new formulation for Amivantamab. So let's start with a publication that I'm not going to go into a ton of depth in the New England Journal of Medicine this week. It's an online first publication, and this is dositamab vedotin plus toripalimab in HER2-expressing advanced urothelial cancer. This is a HER2 targeting antibody drug conjugate with the microtubule inhibitor vedotin or MMAE payload, plus a PD-1 targeting monoclonal antibody for urothelial cancer. This is a study from China, 100% Asian population. We have seen FDA in the past be reluctant to approve drugs that have not been studied in a patient population that's generalizable to the U.S. And so that's one reason I'm a little bit reluctant to get into a ton of depth on this study. That is one kind of flaw from the outside. Another thing that's a little bit odd is that 45, almost 50, almost half of the people on this study had upper tract urothelial cancer. Many of these urothelial cancer studies actually recently have capped the enrollment of upper tract patients at about 20%. So it's heavily enriched with upper tract disease, and they're comparing this. These are untreated metastatic, so first-line treatment advanced urothelial cancer to either HER2 antibody drug conjugate, this novel drug that's not approved in the U.S., and toripalimab, which is approved but probably is not used a whole lot, or to chemo, which is platinum plus gemcitabine. They did not do even adjuvant or maintenance evolumab, and certainly we know that the current standard of care in this patient population is enfortumab, vedotin, and pembrolizumab. So it's not even outdated. The control arm is not even outdated by one era. It's outdated by two eras because it doesn't even have that maintenance immune checkpoint inhibitor. So really, I don't think you're going to see a lot of this. A lot of interest maybe in this coming to the U.S. market. The PFF curves drastically drop off after you stop your chemotherapy. There's some modest OI benefit, but there's a ton of censoring very early on. The reason I bring this up is it's published. We do have the ability to use trastuzumab deruxtecan in advanced urothelial for if they have no other treatment options and they're HER2 positive, so 3+ IHC. This enrolled people with any HER2 positivity, so 1+, 2+, 3+, and seem to have reasonable activity even in 1+. So that's one thing that is a little bit notable here. But really the reason I brought this study up is, it suggests in this HER2 positive patient population, which is a reasonably large subset of, if you take 1+, right? The 3+ is going to be more limited. And we know that trastuzumab deruxtecan in that 3+ setting has response rates of 37% from the label data. So it is a good target, but this would suggest that, maybe these folks could be treated, these advanced bladder, advanced urothelial cancer patients, without platinum-based chemotherapy. And that brings me to kind of the biggest news of 2 days ago, maybe, or yesterday. Which is, the folks who make enfortumab vedotin put out a big press release because enfortumab vedotin plus pembro improves survival in curative setting of muscle-invasive bladder cancer. And this is EV304. This has not been published yet. This is just medicine by press release. But as we're seeing in many of these, like in bladder and in lung cancer, this perioperative approach where you give some doses of drug before surgery, you do the surgery, and then you give them more drug afterwards. And apparently there's overall survival benefit from this. Now, that hasn't been presented, has been published, so we have to see that. But should this hold up, this really does suggest that we're not going to be using, platinum and cisplatin in bladder cancer. That's really what it looks like. And this is, I think, really encouraging and welcome news for the larger bladder cancer patient population who are usually older and don't meet those Galsky criteria, don't have a creatinine clearance above 60. they have a little bit of hearing loss. They don't have a great performance status. They have, some moderate heart failure. They're not going to be able to tolerate a cisplatin-based regimen or a platinum-based regimen. So I think that is certainly encouraging. And then anytime where that makes the treatment more available, and also if it's better in a cisplatin-eligible patient population, I'd suggest it's a pretty darn good treatment. So that is something that we have seen and are continuing to see evolve at a pretty rapid rate here in bladder cancer, which is pretty darn common. Now, muscle-invasive bladder cancer is a minority of bladder cancer patients. Most of them are non-muscle invasive bladder cancer, but we'll probably continue to see this enfortumab vedotin pembro combination be pushed earlier in settings into the non-muscle invasive bladder cancer space. That would be my wager if I were a betting man. Okay, so the next thing I want to talk about is the approval, and I've kind of foreshadowed this, of a subcutaneous Amivantamab. So Amivantamab is a bispecific monoclonal antibody. Now, it's not like the other bispecific. It's not like teclistamab or glofitamab. It's not these other bispecifics where one of the bis, one of the specificities is for CD3 on the T cell receptor. So this is bispecific for EGFR and MET. So it's not a drug that causes cytokine release syndrome or ICANS. So it's a different level of risk. It is a drug, though, that does have a very high risk of infusion reactions, and that has been can be limiting to maybe even the use or adoption of this. And so we have a subcutaneous form. This is Amivantamab and hyaluronidase. The brand name is Rybrevant FastPro. So now you got to separate your two FastPros in your pharmacy. You've got your daratumumab FastPro and Rybrevant FastPro. And if someone is just calling this drug FastPro, you're in trouble. The approval is for all the Amivantamab indications. So with lazertinib for EGFR mutated lung cancer for first line, with carbopem first line for EGFR mutated, carbapen first line for EGFR exon 20 insertion mutations, and then single agent for exon 20 after progression on platinum-based chemotherapy. So, the same indications for Amivantamab. This approval is really based off of the pharmacokinetics of the drug, and really what they're looking at here is the ratio, the geometric mean ratio. So how much drug is left at a trough concentration with the sub-Q compared to the IV, and people are not getting cheaped by the sub-Q formulation. After one dose, there's I think that geometric mean ratio was like 1.1 or 1.2 something. So you're certainly getting enough drug by cycle 4. The trough is 1.4. So in the long run, these folks are getting quite a bit more Amivantamab in the long run. So there is is 1.03 was a geometric mean ratio, so a little bit, basically the same exposure after cycle 1. By steady state, it gets to 1.43, so you're getting quite a bit more drug with the sub-Q formulation. The good news is we do have much lower rates of infusion reactions with this. You're going from 64% infusion reaction, down to something like 13%. So that's very sizable of a decrease in infusion reactions. We see similar rates of rash, nail toxicity, dry skin, maybe a little bit more itching with the sub-Q, a little bit more musculoskeletal pain, probably from getting, maybe a 15 mil or even higher subcutaneous injection, which you can do with the hyaluronidase. Otherwise, toxic profile looks pretty similar. There does look to be maybe a lower rate of VTE, 11% versus 18%. Now, that could have been because IV Amivantamab plus lazertinib, they didn't realize everyone needed VTE prophylaxis right away. So that could be a little bit of an artifact there. But certainly a good treatment option, a safer treatment option from an infusion standpoint or a fusion reaction standpoint. But you still have the same concerns with Amivantamab with all the skin toxicity, the edema and the hypoalbuminemia, which is we have found to be dose limiting in patients. The label does have the updates from the Cocoon study about doxycycline, and then the clindamycin shampoo and the ceramide lotion. All that stuff is in here in our prescribing information as well. I do want to point out here that there's an every 2-week dose and an every 3-week dose. And here's my gripes, okay? So the drug has two formulations. There's a 1,600 milligram formulation that's got 20,000 units of hyaluronidase. That's 10 mil. There's a 2,240 milligram amivantamab formulation. It's got 28,000 units. But there is a 24,000 milligram dose and a 3,360 milligram dose. So we've got 4 different doses, but only 2 different dosage forms. And 2 of these are darn close. 2240 and 2400, and I think there's going to be, maybe some mix up there with 14 versus 15 mil. With prescribing that and giving that. The other reason there can be some errors with this is there's a weight-based dosing for this, but it's not like milligram per kilogram. It's are you under or over 80 kilograms? Like if you're less than 80, you get 1 dose. All right. If you're 80 and over, you get a different dose. And there's a different dose for every 2 week versus every 3 weeks. So you got to look really closely at these doses. And at least in East Tennessee, a lot of our patients are right around 80 kilograms. Some days they're 79, some days they're 81. So that's just it's unfortunate that is the cut point of the higher dose or the lower dose with amivantamab hyaluronidase. But this is something that's been coming for a while. It's had this promising data with lower infusion reactions, which is what we saw as well with daratumab hyaluronidase. So we have this track record, although mechanistically very different drugs with amivantamab. But something to be aware of, something that there are explicit indications in the label about switching from the IV to the sub-Q. There is, of course, sort of a ramp-up dosing with both the IV and the sub-Q, so you just can't switch whenever. You do have to kind of be at that steady state to be able to switch over, whether it's every 2 weeks, if it's like, say, single agent, or with lazertinib, or every 3 weeks if it's in conjunction with chemotherapy. Those are in the label, so all that stuff is in there. So, a new approval to be aware of, to something that I'm sure that we will be looking to add to formulate on top of our IV as well. So it's a little bit of a short podcast this week. Busy time at the end of December. I'm going to try to get that end of the year review of new drug approvals about what are we keeping, what are we regifting, and what are we returning sometime. Maybe not next week because that'll be Christmas Day, but maybe we'll get that. If not, then the following week. But that's what I have for you this week. Thank you for listening. You can follow me on social media at OncoPharm and at PharmDeepNip on X or Twitter. And until I talk to you again, remember, doses matter.